Hello everyone. Today we are discussing a topic called cough. We are familiar with this process, but we are not familiar with the pathophysiology and the pathogenesis pathophysiology, the mechanism, all those things. So now today we'll start with all the overviews like what's the cough reflex, physiology of cough, impaired cough, type of cough, sputum characteristics, approach to a patient, medications and treatment. Now we'll start with cough reflex and physiology. What are the stimulus for a cough reflex? The stimulus for a cough reflex is mostly the chemicals, leukotrienes and histamines. These are all coming due to inflammations and infections. This will trigger the receptors and activate the central nervous system. So the leukotrienes and histamines are the chemical stimulus, while the mechanical stimulus are the foreign bodies, dust, cancers, etc. Next comes the receptor. The receptor is located around the respiratory tracts, the pleura, diaphragm, pericardium, esophagus, stomach, ear. You checking the ear, you should know that if you put a pin or a bud near the ear or superiorly or posteriorly, you will get a cuff reflex. That is because of the nerve stimulation. So the stimulus of the nerves and acting on the afferent nerves to the centers of reflex. Next, we check the afferent nerves. It's a vagus nerve. It's vagus. Vagus nerve means the 10th nerve, means internal laryngeal branch of the superior laryngeal nerve. Okay, that's the afferent. The centers are located in the medulla oblongata and the nucleus of tractus solitarius. The efferent. The efferent is a phrenic nerve, intercostal nerve, recurrent laryngeal nerve. This in case is also a vagus 10th nerve. And where does it act? It acts on the effector muscles. Okay, you should know that what all muscles it acts. It acts on respiratory muscles. Respiratory muscles like laryngeal muscles, then come smooth muscles. These are the muscles in which they act. Okay, so there are three phases basically in a cough reflex: inspiratory phase, compression phase, expiratory phase. First, in inspiratory phase, increase in pressure of lungs. We inspire. The more amount of air enter into the lungs, the contraction of the inspiratory muscles and relaxation of the expiratory muscles accommodate more and more air, which increases the pressure. In compression phase, you should understand that the glottis is closed. The glottis is closed in compression phase. And the expiratory, the tract muscles relaxes or contracted. The tract muscles contract to expel the air, try to expel the air in compression phase. The glottis is closed. In expiratory phase, the glottis opens. Okay. And expel the air or even the foreign body to the opened glottis forcefully. That is expiratory phase. So these are the three phases for a cough reflex. Next comes the topic: what is impaired cough? Impaired or ineffective cough mean it can occur due to several reasons. We have told the reflexes, efferent, afferent, like those things, or the muscles, everything. If any of the problem, pathological problem or the physiological problem happens on such path, the impaired cough occurs. But the problem behind the impaired cough is that it will not clear the foreign body mucus secretions from the lungs or the alveoli out. So it will hamper the effective cough, since we know cough is a very protective reflex. Okay, so what are impaired cough occur? The decreased respiratory muscle strength is one of the cause impaired cough. Next, the chest wall or abdominal pain. Next is chest wall deformities like kyphoscoliosis. Of course, we all know what is kyphoscoliosis. Next is impaired glottic closure or tracheostomy. You know that in this compression phase, the glottis is closed and building the huge pressure inside the lungs, opening the tracts and increasing the pressure of the tracts. That is the compression phase where the glottis is closed. So in tracheostomy and impaired glottic closure, that phase, the compression phase will not occur. In tracheobronchiomalacia, what happened? The expiratory phase is affected. Expiratory phase is probably affected. Why? Because the muscles get collapsed or the alveoli get collapsed during the huge expiration. There is a protective cough reflex. That's the problem with the tracheomalacia. Then abnormal airway secretion hampers the cough, causing impaired cough. Then central respiratory depressions like anesthesia, sedations, coma. These are the central respiratory depressions, which anesthesia, sedations, and coma. Then comes the types of cough. Types of cough. We know there are actually different types of cough, but based on the nature, there are different. But there are two: productive and non-productive cough, or wet cough or a dry cough. So in wet cough, it is mucus production and sputum expulsion. So we can term it in another way that it is a useful cough. It is useful cough. Okay, it's useful. But in dry cough, there is no or little mucus or sputum production. So it is useless cough. In pneumonia, wet cough, the productive cough occurs in pneumonias. Okay, in bronchiectasis, distal alveolar, terminal bronchiolar dilatation, that is bronchiectasis, and lung abscess. But in dry cough, which are non-productive cough, they occur in case of interstitial lung disease, in case of pleuritis, in case of mediastinitis, and tropical pulmonary eosinophilia. Interstitial lung disease, pleuritis, mediastinitis, tropical pulmonary eosinophilia. Then wet cough, that is the productive cough, need to be facilitated. That means it should be facilitated, enhanced, and it should be expelled out. That is, we use expectorants. But in case of a dry cough, which is non-productive, which is useless, and it will be more of a problematic, we use antitussis like codeine medications. Okay, dealing with a dry cough, we can. I will show you one example of a dry cough. So in this example, you can see that the sputum is very less. You cannot hear that sputum gurgling sound or like that. Next is the wet cough, a productive cough. So here you can see that the production of the sputum and the secretions. Brassy cough. Brassy cough, it's a metallic in nature. The brassy cuffs are metallic in nature. They are mostly because of tumors or it can be lymph node. You can also remember a drug which causes a brassy cough due to the bradykinin secretion. That's ACE inhibitors. Okay, ACE inhibitors. Just remember that. That's all. In bovine cough, there is loss of explosive nature. You know, the explosive nature is after compression phase, the expiratory phase, where the glottis open and the huge amount of air comes out through the glottis. So, you know, it's because of the, actually this explosive nature is absent because of the recurrent laryngeal nerve palsy. Okay, so it can be a tumor cause. What occur here, the vocal cord abducts. So whooping cough means continuous cough followed by deep inspiration. Like you can say, like that is it, the whooping cough. Okay, so it's seen in Bordetella pertussis. This is one case. Then in bronchial asthma. And also in case of foreign body whooping cough. Nocturnal cough. When you are considering a nocturnal cough, think about eosinophils or allergic, or think about a tropical pulmonary eosinophilia. Next, it can be paroxysmal nocturnal dyspnea, which is a cardiac cause. So in such case, we see nocturnal cough. Morning cough are mostly bronchial asthma. In bronchial asthma, we also see whooping type of cough. Exercise induced or exertion induced in cough induced asthma. Or we can say it's a cough variant of asthma. Or in congestive heart failure. Suppressed cough we see suppressed cough in case of Mycobacterium avium infection in HIV patients whose CD4 count is less than 50. Okay. We will discuss about sputum characteristics. There are several types of sputum we see. So in serous or water-colored sputum, we can see in case of viral infection. Okay. In viral infection, we see serous or water-colored sputum. Then it is the mucoid sputum, which is thick. In thick, we remember of COPD, chronic obstructive pulmonary disease, and chronic bronchitis. In green colored sputum, always, whatever is green, it's Pseudomonas aeruginosa. Because of, pyocyanin, it's a pigment. Then bronchial asthma, the green color is because of eosinophils. Okay. Next comes the rusty sputum. The rusty sputum is seen in Streptococcus pneumoniae. Next is a red currant jelly sputum. It's seen in a Klebsiella infection. Red currant jelly sputum is seen in Klebsiella infections. Next is black sputum in Kohlberger's pneumoconiosis. Okay. You see black sputum. Anchovy sputum is seen in you see the amoebic liver axis. If it's a rupture above the diaphragm, rupture and go above the diaphragm, we see such anchovy source sputum. It's seen in a rupture of liver axis. Then pink frothy sputum is seen in pulmonary edema. The foul smelling sputum is seen in Lang abscess. In pink frothy, it can be pulmonary due to cardiac cause as well as non-cardiac, both cases. Okay. Next, foul smelling in Lang abscess and aspiration pneumonia. Bronchoria. Bronchoria means what? Bronchoria means the production of sputum more than 100 ml per day. Okay. So it can cause, it is caused by Lang abscess. It is caused by bronchiectasis. It is caused by alveolar cell carcinoma. So we'll talk about the medications given for the cough. Okay. So when you're discussing about the medications, you see that there are pharyngeal demulcents, there are expectorants. Mucokinetics means in the movement of sputum. Antitussives, the cough suppressants in dry cough. So pharyngeal demulcents, what their action is, it smoothens the tracts and prevent the actions of the stimulus. Like we know that the chemical stimulus are there. Okay. So it prevents from acting the chemical stimulus, creating a reflex. So that's we use here lozenges, cough drops, linctus containing syrup, glycerin, licorice. Next year there is expectorants. Expectorants are mucokinetics, which means that it increases the sputum production or enhances the bronchial secretions, and thus allowing you to expel it out, such as sodium citrate and potassium citrate, guaifenesin. In sodium and potassium citrate, the ionic nature of these sodium and potassium is responsible for the secretion, enhancement, and expulsion. Guaifenesin, balsam of tolu, ammonium chloride. And next is the mucolytics, which decreases the viscosity decrease. So that comes the bromhexin, ampreoxol, acetylcysteine, carbocysteine. These are the viscosity reduction. Next is the antitussive, that is cough center suppressants. So we know that dry cough is a useless cough, so use cough center suppressants like opioids, codeine, folcodeine, ethylmorphine. Next, non-opioids like opioids, we know it causes sedation, and side effects of opioids are also problematic there. In non-opioids, we use enoxaparin, dextromethorphan, and chlorpheniramine. Okay. Antihistamines, we know that the leukotrienes and histamines are responsible for the reflex initiation. So we use histamines, antihistamines like chlorpheniramine maleate, diphenhydramine, promethazine. Next, we have peripherally acting, that is prinoxidazine. Next, adjuvant antitussives like bronchodilators like salbutamol and terglutarine. Okay. So among these drugs, we'll check or we'll study the mucus enhancers, secretion enhancers like bromhexin and acetylcysteine. So coming to bromhexin, it's an alkaloid basic sign obtained from Adathoda, the Seika. It's a potent mucolytic and mucokinetic, that is lysing the mucus as well as improving the secretion, enhancing the movement of the mucus. Depolymerizes mucopolysaccharides, tenacious sputum. The side effects are rhinorrhea, lacrimaceae. The adult dose is a tab bromhexin 8 mg TDS. Next, N-acetylcysteine. When dealing with N-acetylcysteine, they open disulfide bonds in the mucoproteins. They're administered directly into the respiratory tract. What can we do? Either we can do a nebulization or we can do a tracheostomy. These are the two ways in which we do nebulization or tracheostomy directly administering in the respiratory tract. Next, the N-acetylcysteine can be in a tablet or injectable form. The dose is 600 milligram BD or TDS. Now it is available in different form, like a effervescence. We can dissolve it in water and drink like a lemon soda. It's more flavored. So these two drugs, this bromhextine and acetyls, are mucolytics or mucokinetics. In codeine and dextromethorphan, we are discussing. We are about to discuss. Both are what we say they are opioids and non-opioid drugs. In codeine, it's a opium alkaloid more selective for cough centers. They suppresses cough for about 6 hours. Next, the abuse liability is low, but still they are present. The side effects of this codeine is it can cause constipation at higher dose. It can cause respiratory depression and drowsiness. So it's contraindicated. It's strictly contraindicated in asthmatic patients. This codeine, okay, because it can cause respiratory depression and drowsiness. In patients with diminished respiratory reserve, and you are not to take these medications during driving. The dose is 15 to 30 milligram. Next comes the dextromethorphan. This is an NMDA receptor antagonist. That is N-methyl D-aspartate. The D isomer has an anti-tussive action, while the L isomer has an analgesic action. They are not addictive or no addiction or no constipation. So these are the preferred anti-tussive. The dose is 10 to 15 milligram. So now we'll discuss how to approach a cough. If a person is coming with cough, how to approach that case. The person is saying that he is having a less than 3 weeks cough, which means an acute onset. 3 weeks, less than 3 weeks. Less than 3 weeks means acute onset, which probably will be foreign body or bacterial or viral infections, respiratory infections. See, in bacterial or viral infections, there can be secretions. Okay, secretions, sputum production, mucus secretions, infections, such that we treat accordingly the antibiotics and symptomatic treatments. That's it. Then for 3 to 8 weeks duration of cough, which called subacute cough, which is mostly a pertussis. Pertussis, we see a whooping cough. Okay, we already discussed the whooping cough. Next is post-viral bronchial hyperreactivity. See, the viral infection, it can cause myalgia, all the body pain, all those things. Usually viral infection causes acute cough. But in some cases, post-viral cases, the symptoms like the myalgia, headache, body pain, all those things will subside, but a small amount of cough will retain. It's probably because of the bronchial hyperreactivity due to the viral infections. So that is about that. Next, if the cough is persisting for more than 8 weeks, which what we call it as a chronic cough. A chronic cough. In chronic cough, the chest X-ray, you ask them to do a chest X-ray because it's a chronic cough and they have done many things to stop or treat it, but they have failed. You start a chest X-ray. You give it chest X-ray. Okay. In chest X-ray, if you find something abnormal, that can be TB, COPD, interstitial lung disease, carcinoma lungs, bronchiectasis. In such case, you can treat the patient accordingly. Okay. Next, if the patient is if the chest X-ray that we have ordered is a bit normal, in 90% of cases, if the chest X-ray is normal, then the problem will be probably a bronchial asthma, or it can be a drug induced, that is AC inhibitors. AC inhibitors, which means it is due to production of bradykinin. Okay, bradykinin is secreted by this AC. So if it is inhibited, it can cause accumulation of bradykinin, which causes brassy cough. What you have to do is you stop the. You can do one thing in AC inhibitor. It is because of bradykinin will produce a brassy cough. And what we can do is you can stop that AC inhibitor for 1 month. You stop the AC inhibitor for 1 month and convert into ARB like losartan, telmisartan, valsartan. If the cough subside within 1 month, then probably it will be because of this AC inhibitor. If the cough is not subsiding, then we can conclude it as there is some other problem. Post nasal drip, what you can consult an ENT surgeon. You can do an endoscopy, nasal endoscopy, or sinus X-rays. You find that any ENT associated problem. In GRD, first we can treat with proton pump inhibitors and antihistamines. These are the drugs which can prevent GRD. If not subsided, then you can go for endoscopy, gastroendoscopy. In such way, you treat the patient. Okay, if no resolution of cough, then go for a CT chest. Why? Because we cannot find everything in a X-ray. You go for a CT chest. CT chest can sometimes it can be a tumor. It can be early interstitial lung disease. It can be early bronchiectasis, atypical mycobacteria. These are very much important because it's very commonly mixed in X-rays. So accordingly you can treat the patient. If you find that CT chest is even normal, then you just reassure the patient that you don't have any problem, don't worry. With the course of time, your cough will get subsided. Okay, you such in some other cases you see that if as we told that in most of the 90% cases where the chest X-ray is normal, it is bronchial asthma. It can be AC inhibitor induced postnasal drip or GRD. But in 5% cases, there is called a cough hypersensitivity. This cough hypersensitivity is similar to the chronic fatigue syndrome. So some what we do here is we give a gabapentin, or we can give pregabalin to stop the cough. Okay. Next is the last topic, that is etiology. So the etiology of cough is treatment. The upper and lower respiratory tract. In upper and lower respiratory tract infection, you can give adequate antibiotic treatment. In smoking, chronic bronchitis and bronchiectasis, you cessate all the following: cessation of smoking. You can avoid pollutants. Then pulmonary tuberculosis, we can give ATT measures, anti-tubercular treatment. In asthmatic cough, we can do beta-2 agonist inhalation, or you can give steroids, or you can give ipratropium bromide. In cough in pulmonary eosinophilia is because of Wuchereria bancrofti. We give DEC for that treatment. We can give also corticosteroids. In postnasal drip due to sinusitis and postnasal due to allergic and perennial rhinitis. These are END cases. END, you should consult an END surgeon. And this allergic and perennial rhinitis can be subsided by using H1 antihistaminics. Here, gastroesophageal reflux, GERD, we can use PPI, antihistamines H2. Perennial and allergic rhinitis, H1, here H2, and proton pump inhibitors. AC inhibitors, that you can go for ARBs. In post-viral cough, usually does not require treatment. Okay, so such is the theology and specific treatment of the cough. So I think you have enjoyed the series of the Harrison lecture, and thank you and have a nice day.